Welcome back to SurgiSmart. We are diving straight back into the deep end today.
Absolutely.
This is part 2 of our 4-part comprehensive series on gastric polyps. And if you missed part 1, we covered the broad classification. But today, we're pivoting.
It's good to be back. And today really is the engine room of the whole series.
It really is, yeah. We're moving past the what and really tackling the why and the how. Specifically, we are focusing on the introduction, etiology, and the epidemiology and pathophysiology.
Right.
To put it simply, we know these lesions exist, we see them on the scope, but what on earth is actually happening at the cellular level to create them?
That is the million-dollar question, isn't it? When you look at a polyp on a screen, it's just a bump. But biologically, it represents a failure of the system, a big one.
Oh, you're of the system.
Yeah. We need to understand the machinery behind it, the environmental triggers, the genetic glitches, the hormonal feedback loops, all the things that allow that tissue to just break the rules of normal growth.
It feels like when you look at the source material, you're looking at two really distinct narratives here.
How do you mean?
Well, on one side, you have the stomach as a sort of a victim of its environment. It's reacting to bacteria, to inflammation, maybe even to the medications we prescribe.
Okay, yeah. The reactive stomach.
And then on the other side, you have the stomach as a prisoner of its own genetic code.
That is a very, very accurate way to bifurcate the discussion. If you want the big picture of polyp formation, you really have two main highways.
Okay.
Highway 1 is exactly what you said, inflammation and environment. This is reactive. The body is trying to heal or compensate for something, and it just overshoots.
And the classic example there has to be Helicobacter pylori.
The usual suspect, always. But then highway 2 is genetics. And this is where the blueprint itself is flawed from the get-go.
So it's not reacting to anything.
Not necessarily. We're talking about hereditary syndromes, germline mutations in genes like EPC or beta-catenin. In these cases, the cells are just, they're programmed to defect regardless of whether there's inflammation present or not.
Let's start with that first highway then, the inflammation connection. Seems like the best place to start.
Agreed.
We know H. pylori is the primary driver for just a massive amount of gastric pathology, specifically hyperplastic polyps. But I want to drill down on the mechanism. It's not really enough to just say bacteria causes polyps. What is the actual chain of custody there?
It's a fascinating, unfortunate cascade. It starts obviously with the infection. H. pylori sets up camp in the mucosa and it induces a chronic inflammatory state.
Right.
But the polyp isn't just a pile of inflammatory cells. That's the key. The real mediator here is a hormone. It's gastrin.
Gastrin. The hormone responsible for acid secretion.
Correct. Now, normally, gastrin secretion is very tightly regulated by the pH of the stomach. Acid goes up, gastrin goes down. It's like a thermostat in your house. But H. pylori, particularly when it causes atrophic gastritis or autoimmune gastritis, it breaks the thermostat.
It breaks it because it's destroying the very cells that make the acid, the parietal cells.
Exactly. In autoimmune gastritis, the immune system directly targets the parietal cells, the acid factories, and that leads to something called oxyntic gland atrophy. The stomach becomes achlorhydric. It just can't make acid.
So the body has no idea.
Well, the body senses the lack of acid and it panics. It thinks, I need to digest this food. So the G cells down in the antrum start pumping out massive, massive amounts of gastrin to try to whip the parietal cells into action.
But the parietal cells are, well, they're dead or dying. They can't respond to the signal.
Right. So you have this state of secondary hypergastrinemia. All these high levels of gastrin are circulating with nowhere to go. And instead of stimulating acid, that gastrin starts to stimulate the proliferation of enterochromaffin-like cells or ECL cells.
And the ECL cells are the precursors to the polyp.
They're part of the puzzle. The gastrin surge causes these cells to proliferate, but it also creates this local environment that's just rich in growth factors and peptides. It's this hormonal soup driven by this desperate attempt to make acid that stimulates the foveolar epithelium to overgrow.
Wow.
And that overgrowth is what we see on the scope as a hyperplastic polyp.
So in a way, the polyp is a symptom of a completely broken feedback loop. The stomach is shouting for acid, and the echo of that shout is what causes a tumor.
That's a perfect analogy. And this whole mechanism, it explains one of the most clinically relevant features of hyperplastic polyps,
Which is?
Their potential for regression.
This is one of the few areas in like oncology where we see something like a spontaneous resolution, right?
Spontaneous might be the wrong word, but it's definitely reversible. The data is quite strong here. If you identify H. pylori as the driver and you successfully eradicate it, and this assumes the patient doesn't get reinfected, research shows that hyperplastic polyps can regress, sometimes completely within a year.
So they essentially just starve. You cut off their supply line.
In a sense, yes. You remove the inflammatory stimulus, you lower that gastrin drive, assuming the atrophy isn't totally complete, and the tissue remodeling just halts. The polyp can shrink, or in some cases, disappear entirely.
And this isn't just with H. pylori.
Well, it's been observed with the cessation of antacid therapy in some specific contexts too, but H. pylori eradication is really the big one. It's the most dramatic example.
But we have to be careful, right? We can't just paint these as purely benign reactive bumps. The background mucosa, the lawn it's growing on, is often in really bad shape.
That is the critical point for the surgeon or the gastroenterologist. The polyp itself might be manageable, but the lawn it's growing on is diseased. H. pylori causes intestinal metaplasia.
Right.
And we know this sequence well. The stomach lining, under all this chronic stress, changes its phenotype. It starts to look more like the intestine.
Which is a defense mechanism, I thought.
It is, but it's a maladaptive one. Intestinal metaplasia confers a significant risk for gastric cancer. We're talking up to a 10-fold increase compared to the general population.
Wow.
So even if you get rid of the H. pylori and the polyp regresses, that patient is still in a high-risk category for life.
Let's talk numbers for a second. Who gets these? Is there a demographic profile we should be watching for?
It's often tied to lifestyle factors that, just exacerbate that inflammatory state. Smokers, people with a really high salt intake, these are very common correlations.
Okay, that makes sense.
But there is an interesting epidemiological nugget that came out of the source material regarding liver disease.
This surprised me. Patients with chronic liver disease or cirrhosis have a higher incidence of these.
Significantly higher. They develop hyperplastic polyps more frequently than patients with, say, standard GERD.
Why is that?
The exact mechanism isn't fully elucidated, but it likely relates to the clearance of gastrin and other hormones by the liver. If the liver is failing, those growth factors just stay in circulation for longer, stimulating more growth.
That's fascinating. Okay, so we have a patient, they have hyperplastic polyp, we treat the H. pylori, but do we still need to worry about that polyp itself turning into an adenocarcinoma?
We do. Absolutely. The malignant transformation rate is, it's estimated to be somewhere between 0.6% and 8%.
That is a massive range. I mean, 0.6% is basically negligible, but 8% is clinically urgent.
It is a big range, and it reflects the heterogeneity of the studies and the populations they looked at. But the bottom line is we have to treat the risk as real. The sequence is the classic pathway. Hyperplasia leads to dysplasia, which can then lead to carcinoma.
Do we know the molecular drivers of that switch? I mean, at what point does a reactive polyp become a neoplastic killer?
We're starting to map it out. We see p53 mutations, KRAS mutations, and even APC mutations appearing in these lesions as they transform.
The same genes we see in other cancers.
The very same. High Ki-67 labeling indices, which is just a way to measure how fast cells are dividing, are also predictive. Clinically, you start to worry more if the patient is older, if the polyps are large, pedunculated, or if there are a lot of them.
Okay, the specific question on recurrence. If you snare a hyperplastic polyp and it grows back in the same spot, does that imply a higher risk of malignancy?
You'd think so, but counterintuitively, no. Recurrence is actually pretty common if the underlying driver, that gastritis, isn't fixed.
So it's just the soil is still fertile.
Exactly. But recurrence alone is not considered an independent risk factor for malignant transformation. It just means the conditions are still right for polyps to grow, not necessarily for cancer to develop.
All right, let's pivot to the second major category. And this one is fascinating because it deals with iatrogenic causes, things we do.
Right.
We're talking about the medications we prescribe every day, proton pump inhibitors, or PPIs, and their link to fundic gland polyps.
This is what I like to call the PPI paradox. We give these drugs to protect the stomach, to stop acid, and yet they fundamentally alter the histology of the organ.
So walk us through the mechanism here. It seems similar on the surface to the H. pylori story. Blocking acid leads to a rise in gastrin. But the outcome, the polyp itself, is structurally very different.
It is. So you take a PPI, it blocks the proton pump in the parietal cell. Acid secretion plummets.
Right.
The stomach senses this, and again, it raises serum gastrin levels. You get hypergastrinemia. But here's the key difference. The parietal cells aren't destroyed like they are in autoimmune gastritis. They're just blocked.
So they're still there, and they're receiving the signal to work, but the machinery is just jammed.
Precisely. This leads to parietal cell hypertrophy. They physically get larger, trying to overcome the block. At the same time, the foveolar cells, the ones lining the gastric pit, they start secreting mucin deep inside the gland.
So you have these big swollen cells blocking the exit, and then you have all this mucin filling up the room from the inside.
Exactly. It's a plumbing obstruction at a microscopic level. The parietal cells block the isthmus of the gland, the mucin backs up, and cysts form. Those cystic dilations are what we identify as fundic gland polyps.
It's a purely mechanical and hormonal consequence of the drug. That's incredible.
It is.
But the big question for our listeners has to be, are these dangerous? I mean, we have millions and millions of people on chronic PPIs. Are we creating a cancer epidemic?
Generally, no. And this is where we have to be very, very precise about the genetics of the situation. We divide fundic gland polyps into two main camps, sporadic and syndromic.
And sporadic are the ones we see in PPI users.
That's right. In these sporadic cases, we often find activating mutations in a gene called beta-catenin.
Beta-catenin.
Yes. This mutation helps drive the growth, but, and this is the most important part, the risk of malignancy in these sporadic PPI-associated polyps is incredibly low, less than 1%.
So it's effectively a benign, almost cosmetic change in the stomach lining.
For the vast majority of patients, yes. That's a good way to think about it.
Okay, so now contrast that with the syndromic cases.
This is where we get into familial adenomatous polyposis, or FAP. These patients have a germline mutation in the APC gene.
The big one.
The big one. APC is a tumor suppressor. When it's inactivated, the brakes are off. The cells just go.
And do these polyps look different on the scope?
Sometimes they can, yeah. FAP-associated fundic gland polyps are much more likely to harbor low-grade dysplasia. They also tend to be larger, often over a centimeter. But even then, and this is the strange part, the progression to gastric adenocarcinoma is still quite rare.
That's really surprising to me. FAP is basically a death sentence in the colon if it's left untreated. Why is the stomach so much more resilient to the same genetic flaw?
It's one of the great mysteries of GI pathology. We don't have a perfect answer. The gastric mucosa just seems to handle the loss of APC function better than the colonic mucosa does. Malignancy usually only happens when the polyps are massive. We're talking greater than 3 centimeters, and there are just hundreds or thousands of them.
But FAP patients can get other things in the stomach.
They can, and that's the catch. They can develop true adenomas in the antrum, the lower part of the stomach, and those are much more concerning.
So in an FAP patient, the stomach is actually a mix of different pathologies.
Exactly. You might see thousands of relatively benign fundic gland polyps in the body of the stomach, and then a handful of potentially pre-malignant adenomas hiding out in the antrum. It's a complex picture.
Before we move on, I want to touch on GAPPS. It sounds like a clothing store, but it's a very specific genetic entity, gastric adenocarcinoma and proximal polyposis of the stomach.
GAPPS is a crucial diagnosis to keep in mind because recognizing it saves lives. It's an autosomal dominant condition, and it involves a very specific mutation, the APC promoter 1B.
And the distribution of the polyps is the clue, right?
It's the definitive clue. In GAPPS, you see this profound carpet-like polyposis, but it's only in the proximal stomach, the body, and the fundus. The antrum is spared. The duodenum is spared. And most importantly, the colon is completely spared.
That is absolutely vital, because if you misdiagnose this as FAP, you might end up taking out a perfectly healthy colon.
Exactly. Recognizing the geography of the polyps tells you which segment of the gene is broken, and that dictates the entire surgical strategy.
Let's move to our third section, the hormonal feedback loop, focusing specifically on neuroendocrine tumors, or NETs, and adenomas. We touched on that autoimmune cascade earlier, but I want to map it directly to these specific tumors.
This is really the end stage of that aqua hydri story we started with. We talked about how autoimmune gastritis leads to parietal cell death and then hypergastrinemia.
Right.
If that intense stimulation continues for years or even decades, the enterochromaffin-like cells, the ECL cells, they don't just proliferate, they actually transform.
They form full-blown tumors, and this is where we get the different types of NETs.
Correct. Type I is by far the most common, and it's associated with that autoimmune atrophic gastritis background. Because the drive is hormonal from the gastrin, these tumors are usually small, there are multiple of them, and they're indolent. They behave relatively benignly.
Because they're dependent on that hormone signal.
Partly, yes. In fact, if you cut the gastrin supply, for instance, by performing an enterectomy to remove the G cells, the tumors will often regress.
Then there's type 2.
Type 2 is rare. It's associated with MENI, multiple endocrine neoplasia, or Zollinger-Ellison syndrome. In this case, you have a gastrin-secreting tumor, a gastrinoma, somewhere else in the body that's driving the stomach crazy with gastrin.
So the stomach is the victim again.
Exact.
And type 4. I noticed the source material skips type 3, likely because it's sporadic and not driven by this specific feedback loop. But type 4 is mentioned.
Type 4 is the outlier. It's linked to acid deficiency just like type I, but its biological behavior is totally different. It tends to present as a single, large, and highly aggressive tumor. It's often advanced at the time of diagnosis.
We also need to define gastric adenomas in this landscape. They aren't neuroendocrine, they're epithelial, right?
Correct. Adenomas are true neoplasms. They are the direct precursors to adenocarcinoma, and they typically arise in that same bad soil, atrophic gastritis, and intestinal metaplasia.
And they have subtypes based on what they look like.
Yes, based on what cell type they are trying to imitate. You have the intestinal type, which is full of goblet cells, the gastric type, which is lined with gastric foveolar cells, and then you have indeterminate types. But honestly, regardless of the type, finding an adenoma is a huge red flag. It means the genetic stability of that mucosa is gone.
This brings us to section 4, which is basically what I call the look-alike problem. We have this whole roster of hereditary syndromes that produce gastric polyps. The challenge is that when you're looking through the endoscope, a polyp is a polyp is a polyp. You can't necessarily see the gene mutation.
That is the clinical trap. You cannot reliably distinguish a syndromic polyp from a sporadic hyperplastic polyp just by gross inspection. You need the biopsy, you need the family history, and you need the systemic context.
So let's run through the rogues gallery. First up, Kuss-Jegger syndrome.
Right. This is caused by an STK11 gene mutation. It's autosomal dominant. These patients develop what are called hamartomatous polyps.
And hamartoma means it's organized, but disorganized.
That's a great way to put it. It's all the right tissue in the right place, but it's growing in a chaotic, disorganized way.
Yeah.
Histologically, Peutz-Jeghers polyps are beautiful in a terrifying kind of way.
How so?
They have this arborizing tree-like framework of smooth muscle that branches out through the entire polyp. It's unmistakable under the microscope.
And the cancer risk.
It's a systemic time bomb. The risk of GI cancer is high, yes, but also pancreatic, breast, ovarian, testicular, and lung cancers. If you see that tree-like polyp in the stomach, you have to screen the whole patient from head to toe.
Okay, next on the list is Cowden syndrome.
This is a PTN mutation. PTN is a phosphatase that helps regulate cell division. When it's broken, you just get overgrowth. These patients have multiple hamartomas in the stomach, skin, and mucous membranes.
And the systemic associations here are quite specific, aren't they?
They are. Breast, thyroid, and endometrial cancers are the big three you worry about. But interestingly, there's also a strong link to autism spectrum disorders and macrocephaly, which is a large head size.
So that's a clinical pearl.
A huge one. If you have a patient with gastric polyps, a history of developmental delay, and a large head circumference, you have to be thinking about Cowden syndrome.
That's fascinating. What about Cronkite-Canada syndrome? It sounds like a geographic expedition.
It's the odd one out because it's not hereditary. We don't actually know what causes it. It presents with this diffuse polyposis in the stomach and colon, but the real telltale signs are ectodermal.
So hair, skin, and nails.
Exactly. Alopecia, which is hair loss, on onychodystrophy, which is nail damage, and skin hyperpigmentation. On top of that, they have a severe protein-losing enteropathy. They're profoundly malnourished and very sick.
And lastly in this group, juvenile polyposis.
Caused by SMAB4 or BMPR1A mutations. And despite the name, it definitely affects adults. The polyps are hamartomas, so often very large, and they cause obstruction and bleeding. And like Cronkite-Canada, it causes a significant protein loss. The stomach is literally weeping protein into the lumen.
It really emphasizes that the stomach can be a window. You look in via endoscopy, but what you're actually seeing is often a manifestation of a systemic genetic state.
Absolutely. The polyp is just the tip of a very large and often very dangerous iceberg.
Now, I want to shift gears completely for section 5. We are leaving the mucosa of the lining and we're going deeper into the wall of the stomach itself. We're talking about the mesenchymal tumors.
This is where we stop talking about glands and start talking about structure, muscle, nerve, connective tissue.
And the heavyweight champion in this category has to be the GIST, the gastrointestinal stromal tumor. But I love the origin story of these cells. They aren't just muscle, and they aren't just nerves.
No, they arise from the interstitial cells of Cajal, the pacemaker cells of the gut.
Which is just such a cool concept.
It is. These cells sit in between the nerve endings and the smooth muscle layers, and they coordinate the peristaltic wave that pushes food through. Gists are tumors of these pacemaker cells.
And biologically, what's the driver?
In the vast majority of cases, it's an activating mutation in the CK2 proto-onc gene, or, less commonly, the PDGFR gene, which is the platelet-derived growth factor receptor.
And these are both tyrosine kinases.
Correct. The mutation basically causes the on switch for cell division to get stuck. The cell just thinks it needs to divide constantly, forever.
And this is why GISTs were such a revolution in oncology, right? Because we found a drug, imatinib, that specifically targets that exact broken switch.
Exactly. It's the poster child for targeted molecular therapy. But before you can treat it, you have to diagnose it. And that brings us to the histology and the lookalikes.
Right, because under the microscope, they can look like a lot of other things.
They're usually composed of spindle cells, these long, slender cells arranged in bundles or fascicles, but so are smooth muscle tumors, which we call leiomyomas, and nerve sheath tumors, which we call schwannomas.
Okay, so walk me through the detective work.
Yeah.
For the pathologist, you get a slide. It's full of spindle cells. How do you figure out what it is?
You have to run the immunohistochemistry panel. It's a process of elimination. First, you stain for KIT, which is also known as CD117.
If it glows positive for chick.
It is almost certainly a GIST. About 95% of them are positive.
Okay, simple enough. But what if it's negative for KIT?
Then you move on. You look for a protein called desmin. Desmin is a protein found specifically in muscle tissue. If it's desmin positive and KIT negative, you're looking at a leiomyoma, a benign, smooth muscle tumor.
And if it's negative for both of those?
Then your last stop is to stain for S100. S100 is a marker for neural crest-derived tissue, specifically Schwann cells. If S100 is positive and the others are negative, it's a schwannoma.
So the triad is KIT, desmin, and S100.
That's the golden triad. That's how you tell them apart.
There's one more entity in this mesenchymal group that has a really distinct look. The inflammatory fibroid polyp.
Ah, IFPs. These are benign submucosal lesions. They're thought to be reactive, and they're composed of vascular fibrous tissue that's just infiltrated with inflammatory cells, especially eosinophils.
And the visual hallmark.
It's the onion skin appearance. The stromal cells swirl around the blood vessels in these concentric rings. Just like an onion, it's a dead giveaway.
And surprisingly, even these have a specific genetic driver, don't they?
They do, which is fascinating. They often harbor activating mutations in the PDGFRA gene, the same family as the GISTs. So even these benign, inflammatory-looking fibrous lumps have a specific genetic basis.
This leads us perfectly into our final section, the detective work of histopathology. We've mentioned corkscrews and onion skins and trees, but I want to synthesize for the audience why the biopsy is so completely non-negotiable.
It really comes down to one simple fact. The endoscope is a macro tool. It shows you shape and color and size, but it cannot show you cellular intent. You cannot reliably diagnose dysplasia, that precancerous change, just by looking at the surface of a polyp.
You have to see the architecture.
You absolutely do. Let's just quickly review those visual cues we've discussed just to paint the final picture for the listener.
Okay. Hyperplastic polyps.
You're looking for the corkscrew. The foveolar pits are elongated, they're twisted, they're dilated because they're growing way too fast. And the stroma between them is edematous. It's swollen with fluid and inflammatory cells.
Pyloric gland adenomas.
Very different. They have a ground glass cytoplasm. The cells lack that normal cap of mucin you see, and the tubules are packed back to back, just incredibly crowded.
And for the big syndromes.
Peutz-Jeghers is the tree. You see these thick bands of smooth muscles splitting and branching throughout the polyp. It's unmistakable. Juvenile polyposis is more like a swamp. A lot of edematous lamina propria, dilated glands filled with mucus. It just looks disorganized and wet.
And finally, for the neuroendocrine tumors, we rely on a specific speedometer, the Ki-67 index.
Yes. Ki-67 is a protein that is only present when a cell is actively in the process of dividing. So we stain for it, and we calculate a percentage of positive cells.
So if the Ki-67 is, say, 1%.
That means only 1% of the tumor cells are actively dividing at that moment. That's a low-grade tumor, a type I or type 2. It's growing very slowly.
But if it's 20%,
Now, that's a high-grade tumor, a type 3 or a neuroendocrine carcinoma. It's aggressive. It tells the surgeon and the oncologist that this isn't something you can watch and wait on. You need to act, and you need to act fast.
this has been just a massive download of information. We've covered bacterial triggers, genetic syndromes, drug-induced changes, mesenchymal anomalies, the whole gamut.
It's a heavy topic for sure, but it's absolutely foundational to understanding this disease.
So if we have to synthesize all of this for the listener, the surgeon, the student, the curious mind, what is the headline for part 2?
The headline is that the stomach is a profoundly reactive organ. It is not a passive bag for food. Whether it's reacting to an H. pylori infection by pumping out gastrin, or reacting to a PPI blockade by growing cysts, or reacting to a broken APC gene by spawning thousands of polyps, every single lesion is a symptom of an underlying cellular struggle.
So the polyp is the smoke signal.
Precisely. And our job as clinicians is to figure out if the fire is a small contained campfire, like a sporadic fundic gland polyp, or if it's a raging forest fire, like FAP or a high-grade dysplasia.
I want to leave everyone with a final provocative thought to chew on.
Hmm.
We talked about how H. pylori eradication can literally make a tumor disappear.
Mm-hmm.
That implies that the tumor is completely dependent on its environment. But then in a case like FAP, the tumor is inevitable purely because of the genetic code.
It creates this fascinating dichotomy, doesn't it? In one case, you treat the patient by changing their environment with a simple course of antibiotics. In the other, you might have to remove the entire organ because the environment doesn't matter one bit.
It really challenges the very definition of disease. Is the disease the bug, or is it the body's reaction to the bug? Or is it just the body itself?
And that is the perfect cliffhanger.
Because in part 3 of SurgiSmart, we're going to take all this pathology, all these risks and drivers we've discussed, and we're going to talk about management. When do you cut? When do you scope? And when do you just watch and wait?
I can't wait. That's where the rubber really meets the road.
Thanks for diving deep with us today. We will see you for part 3.